What's up, guys? Sorry, I was actually just live a second ago, but there was no sound, and that kind of happens because every day I kind of have to turn on the mic, and I forget to do that, and I don't leave it on all the time because I don't use it all the time. But yes, so now we're finally up to neoplasms of the skin, where we're basically gonna see some of these skin lesions that are either neoplastic and malignant or neoplastic and pre-malignant. A lot of them are just benign, as in they are neoplastic, but they don't do anything. Keep in mind from step one pathoma and the basics of pathology in general, what makes cancer malignant is its ability to metastasize, and then of course how much damage it causes wherever it is, right? So now some of these neoplastic skin lesions, they don't really metastasize, and many of them don't really cause much lesion damage where they are either. They just look weird wherever they might be. But what can become problematic is the ability to develop into something else, right? And that's also problematic. So if you have a lesion and it is cancerous, but it's not that bad, but it can develop into something that is bad, then that's still something, a risk factor you have to consider, right? So first thing we have here is seborrheic keratosis. Now, seborrheic keratosis looks like this. As you see this image right here, it's pretty much always going to be this dark, right? And it's also easy to identify even on darker skin. So like I said in some of these earlier dermatology videos, that most lesions that they're going to show you in any image in books is going to be on white skin so that you could see the lesion, right? So that nothing else is going to distort the color and the design and whatever else appearance of the lesion. But this same lesion, you have to make sure you look them up on black skin too, right? So very important to go ahead and Google images where you look up seborrheic keratosis and then try to see if you can find it on a black patient, because it's gonna pop up. It's very possible that on your step exam, the patient that they give you an image of is on a black patient, right? So you don't want to get messed up by that. Now this thing, this is pretty cool because it's very different from everything else we're going to see later on. Seborrheic keratosis has these little things in there too. So you see all these little they look like, I don't know, like little raisins inside, right? So those things are very peculiar here, and they really help identify seborrheic keratosis from pretty much anything else that might be in your answer choices. So it says here it's a very common skin tumor that appears in almost all people after 40 years of age, which means it's extremely high yield, extremely common. And if you haven't seen somebody with it, if none of your family members that are very elderly have it, or someone friends of family members have it, then that's pretty crazy, because almost everyone does get it. And most of you guys watching this video, at least one person will definitely get it at some point. It's just extremely common, and it's not malignant, right? So lesions have no malignant potential. It is a neoplastic thing. It's just not malignant. It looks really bad, like not ugly bad, but like it looks like it's something that could be problematic, but it's not. Presents as an exophytic waxy brown papules and plaques with superficial keratin cysts, and those are the things I was circling, right? So those are your keratin cysts that they're kind of talking about. Lesions may appear in great numbers and have a stuck-on appearance, which basically means that this entire thing looks like you can actually grab it and just pull it off, right? So it is almost like a big bump coming off the skin, right? So it's a big bump coming off the skin. It's all black, and it has little keratin horns, or keratin cysts as they may call it. And it's very easy to identify compared to other things. So always compare things too. Always compare lesions in dermatology, because that's exactly what you're going to be doing in your questions, right? You're going to get questions with answer choices that are going to have everything there, all the differentials there. So you have to be able to compare them in terms of how they look, as well as how you verbally describe them, right? Because not always are you going to have answer choices and images to work with. You're going to have verbal descriptions of things, and when you start practicing medicine and you have to call your attending or something to explain something to them, you're going to have to give verbal explanations. You're not going to WhatsApp them a picture of the lesion on your patient, right? So that's something that you have to get very good at. So lesions appear stuck on, and you note these superficial keratin cysts. So seborrheic keratosis always rings a bell for me and makes me remember this. I've seen so many seborrheic keratosis questions over time that it just stuck to me, and looking up more images on Google will always be very helpful. Characteristic exam findings and history are sufficient. You don't need to do anything. As we've seen throughout dermatology, you do not do some kind of weird biopsy or anything strange like that. Looking at a lesion and knowing the history of a patient and their demographics and stuff will be more than enough to come up with a diagnosis. As some may appear similar to melanoma, though, a biopsy may be prudent in these cases. Now, it is still very unlikely for something like this to appear like melanoma if it's developed to this stage. If you remember, melanoma had a couple things like the ABCDs of memorizing what you would see in melanoma. But first of all, melanoma is not a stuck-on appearance, right? It's not something that's going to be plopping out of the skin. It's also almost never perfectly round, right? So it's going to have irregular borders and stuff like that. And let me see, it was all mentioned right here. So ABCDEs, right? Asymmetry, border irregularity, color variation. It can be like super dark and light dark in some places, and then it does change over time. Right, there's many types of melanoma, but this, if your seborrheic keratosis on the patient looks like this is never going to look like melanoma. But there are other variations of this that could look like melanoma. So that's the only time you would have to do a biopsy just to exclude melanoma. So you're basically not doing a biopsy to diagnose seborrheic keratosis. You're doing a biopsy to exclude melanoma because melanoma is pretty malignant. Treatment is simply to get rid of it, right? So cryotherapy, shave excision, or curettage. Very straightforward, which is why it's not malignant, right? The lack of depth and invasion and spread throughout the body is what makes it not so malignant at all. Then the next thing, actinic keratosis. Now, when we did our step 1 videos, I made up this thing. I said actinic keratosis has a lot of action, right? Working off of the first few letters of this word, ACT. So actinic keratosis has action. This is actually something that has a possible transformation into squamous cell carcinoma. So it could become dangerous, all right? Flat areas of erythema and scale caused by exposure to the sun. These lesions should be treated to prevent possible transformation into squamous cell carcinoma. Lesions appear on sun-exposed areas like the face and arms, and primarily affect older patients who often have multiple such lesions. They're erythematous with a gritty texture that can become thick and crusted. Okay, so we're seeing this is the image given in the book. This is something I put here from a UWorld question. So let's see what else they tell you. Diagnosis, of course, clinical. Treatment, just get rid of it, right? Cryosurgery, topical 5-fluorouracil, or topical imiquimod can be used to destroy the lesion. If carcinoma is suspected, perform a biopsy. Patients should be advised to use sun protection. So in this image here, right, the discrete patch above has an erythematous base and a rough white scale. This is also often described in questions as something that appears horn-like. Okay, so it's always... here in this image, they're showing it to you on the ear. There will be patients that will have it on their forehead. It's often also linked to patients who are farmers or something, right? So again, always coming back to here to refer to more, right? So over here you can see first image is actinic keratosis on the scalp, and the second image is actinic keratosis on the ear. So you can see how both of these look. Right, actinic keratosis, pre-malignant lesion caused by sun exposure, small, rough, erythematous, or brownish papules or plaques. Risk of squamous cell carcinoma is proportional to the degree of epithelial dysplasia. How bad is the actinic keratosis? And I wrote here that seborrheic keratosis is benign, but actinic keratosis has action because it can become squamous cell carcinoma. Right? So, as usual, first ACK tells you how to deal with it and how to diagnose it and stuff like that. But more knowledge is always going to come from the first aid step 1. So I always go back to that for my video purposes. Of course, people studying use many other resources as well. But everything I have here is pretty complete in that sense. This image here is keratosis pilaris. It's a benign condition characterized by retained keratin plugs in the hair follicles. Painless papules, roughened skin texture, and mottled perifollicular erythema, usually on posterior surface of the upper arm. Exacerbations are common in the cold and dry weather, and if necessary, treated with emollients and topical keratolytics. The reason I put it here is because this also has keratosis in the name, and the question that this image came from had both of these as answer choices, seborrheic as well as actinic keratosis, right? But it wasn't either one of them, of course, right? Seborrheic keratosis would be big, it would be really dark, and it would have little cyst things on it, whereas actinic keratosis would really just be on the face or ear or some other heavily sun exposed body part. The next page, let me see what Hamad. Also important to know is that sudden onset of seborrheic keratosis is sign of underlying GI cancer. Was it the seborrheic keratosis that did that? Let me just check something real quick. That does ring a bell. But was it seborrheic keratosis? I'm not sure. Because there's a couple things that are signs of underlying GI cancer. Sudden appearance of seborrheic keratosis. Yeah, right here. Seborrheic keratosis. Oh yeah. The lesser Trellas sign is also seborrheic keratosis. Okay. I always forget that connection. So good point, Hamad. People that have the lesser Trellas sign, which looks exactly like this one right here. So you can see how both of these are dark, right? This is the same seborrheic keratosis image, and then L is showing you the lesser Trellas sign, which you have a bunch of really dark, sudden appearance of seborrheic keratoses all over the back. So again, for completeness purposes, right, great thing to come back here and look at it. So I didn't look at seborrheic keratosis so far right now when we were doing the video. I was actually not gonna come back to this page, but yeah, seborrheic keratosis is mentioned here under common skin disorders because it's not really that malignant, it's not really that problematic, but as a lesser Trellas sign, it's pretty malignant, right? So rapid onset of multiple seborrheic keratoses indicates possible malignancy such as GI adenocarcinoma, which looks, so the sudden appearance, the lesser Trellas sign looks like this, and when this happens, then you go ahead and order stuff like colonoscopy and etc to rule out any possible GI adenocarcinomas. So yeah, that was a good point to bring up. Thank you, Hamad. Let me come back to where we were. Okay, right here. So, and then we looked at actinic keratosis, dealt with that, right? So actinic keratosis has more action because it can transform. Next thing here, cutaneous squamous cell carcinoma. So now squamous cell carcinoma, basal cell carcinoma, and melanoma, those are basically the last few really bad things, and then the rest of these are pretty bad, but not they don't go together. So these three are going to often be the same answer choices, like answer choices for the same question. So what is really critical about squamous cell carcinoma, and what is really critical about basal cell carcinoma? Well, recently in first aid, right, they started doing this thing, which kind of helps you remember that basal cell carcinoma is more common on the upper lip and basically above the upper lip, whereas squamous cell carcinoma is more common on the lower lip and below. All right, so that's a pretty easy thing to remember, and it's a very critical way to actually be able to differentiate between one answer choice over the other. Otherwise, they kind of tend to look very similar as if you just look at the lesion. Squamous cell carcinoma is the second most common skin cancer with locally destructive effects, as well as the potential for metastasis and death. Overall, which, all of this together, destructive effect and metastasis, makes it pretty malignant. Sun exposure is the most common causative factor, but exposure to chemical carcinogens, prior radiation therapy, sites of burn, or chronic trauma, as in draining infectious sinuses in osteomyelitis, and chronic immunosuppression, such as in transplant patients, also predispose patients to developing squamous cell carcinoma. So if you think of this as a test writer, this gives you many ways to start off the question, right? You can have a patient who, the question might start off with a patient who has really bad diabetes, ended up getting osteomyelitis. You drained all the osteomyelitis. 2 weeks later, they come back with a weird lesion, and then boom, it's like this. Right, so then you have to think of squamous cell carcinoma. So this kind of information that they give in the book here is really just helping you paint pictures of all the different variations of patient presentation you can have. Squamous cell carcinoma have many forms, and a single patient will often have multiple variants. Most squamous cell carcinomas occur in older adults with sun-damaged skin arising from actinic keratoses, presenting as an erythematous, ulcerated papule, or nodule. Margolin ulcer, this thing is different, is a type of rare squamous cell carcinoma that arises in sites of scars, burns, or ulcers. And arsenic exposure is a rare cause of multiple squamous cell carcinomas in a palmoplantar distribution. Squamous cell carcinoma from actinic keratoses rarely metastasize, but those that arise on lips and ulcers are more likely to do so. Squamous cell carcinoma occurs on the lower lip more commonly than basal cell carcinoma, as we saw from the previous page from the step 1 book. Diagnosis, again, characteristic exam findings and history are more than enough. You can confirm with a shave biopsy, not a punch biopsy. So a shave biopsy just takes off some of the the cancerous lesion from the top, right? A punch biopsy is more problematic aesthetically. And then when you do that, you're going to see keratin pearls and full thickness atypical keratinocytes with invasion into the dermis, right? So the keratin pearls being the main thing for squamous cell carcinoma. Treatment, surgical excision, or you could do something called a Mohs surgery. So Mohs surgery is basically you take very thin slices, right? Very thin slices are excised and examined with the microscope via frozen section, ideally used for cosmetically sensitive areas such as face and distal extremities. Lesions with high metastatic potential may need radiation or chemotherapy. Right? And this was the URL table here, pretty much listing out the same kinds of things, nothing crazy. And you can see the lesion here. In step 1, they have a different lesion, right? So for, let me see, squamous cell carcinoma J, K, and L. So you can see right here, right? J, K, and L. Right? So in L, they're actually showing you the keratin pearls that you're supposed to be seeing, right? So nice and pink keratin pearls. And then K is showing it to you on the lower lip, and J is showing it to you on the face, right? So it's kind of like that. This looks like it's on the nose. So now combined, this kind of messes things up, right? Because we just said that basal cell carcinoma is going to occur on the upper lip and mainly above places on the upper lip. So like on the cheek and stuff, but this is actually above the upper lip, right? So the thing is really just, focus more on the lip aspect. If it's on the lower lip, it is definitely squamous cell carcinoma, and then this is squamous cell carcinoma, and of course if you do the histology, it's a squamous cell carcinoma. How does squamous cell carcinoma actually visibly, if you don't look at anything else but just the lesion, right? So don't look at the fact that this is on the nose, don't look at the lips, right? How does it actually look different from basal cell carcinoma? Well, it actually looks pretty freaking different. Basal cell carcinoma is images A through D. So look at this, right? This is so waxy looking. This one actually looks like you took a really hot metal pin and you put the metal pin right here and melted everything, right? And not only does it look like something melted, but it also has this weird nodular thing it does, okay? Weird nodular thing it does that is very iconic to this. In the next lesion, which is also in the same area as this image is, right, pretty much on the nose, you can see critical differences between here and here, right? This literally just looks like it's a pretty bad cut he has on the nose or something. And then here you can see there's a lot of different kinds of things happening, right? There's the darkening, there's the crusting. It actually looks like you can cut this off and then it's going to bleed or something. Right, so that's pretty critical. And then if you look at image C, again, very different kind of thing there, right? So they tell you scaling plaque, superficial basal cell carcinoma, right? So the point is, basal cell carcinoma, I like to say, looks a lot cleaner than squamous cell carcinoma. You see how weird and dirty this looks, right? Whereas this is definitely much cleaner. It looks like it's just clean skin that has obviously got some kind of disease on it. And then histologically, of course, you see no keratin pearls here, no keratin pearls whatsoever, right? And what's happening is this invasion is what's happening, right? So you're really going deep into the dermis right there, right? So they call it the palisading nuclei, which basically means palisading is kind of like building a fence, right? And that's kind of what's happening with this. So this is that fencing that's occurring. And those are all things that are often going to be given to you in an explanation. They're verbally going to tell it to you. They're going to verbally explain it to you. Not always are they going to show it to you like this. These images are here, of course, for learning purposes. As doctors, we need to know what we see when we see a patient that presents. But in book practice and in basically on your step exam, they're going to describe it to you, right? So they're going to describe it to you. So that's the next thing. Let's take a look at the next thing, basal cell carcinoma. Right, so we talked a little about this already, and you can see how this is definitely cleaner looking than this, right? Very big difference in terms of appearance. The most common malignant skin cancer, right? So we just said squamous cell carcinoma was the second most common. This is the most common. Basal cell carcinoma is the most common malignant skin cancer, basal cell carcinoma, is slow growing and locally destructive, but has virtually no metastatic potential, right? No metastatic potential, which makes it pretty nice. It's Basal is basic, is what I like to say, so it stays where it is. Excuse me. Whereas squamous cell has a pretty good high chance of metastasis, as well as just destructive effects in general. Most lesions appear on the face or other sun-exposed areas. Multiple basal cell carcinomas appearing early in life and on non-sun exposed areas are suggestive of inherited basal cell Nevis syndrome. Right, so again, you can get a question where they might show you basal cell carcinoma, they might explain basal cell carcinoma stuff, but then remember, diagnosis is made by history and presentation as well, right? Not just looking. So if the history and presentation is of a guy who's really not done much in the sun, and he has sudden appearance of a bunch of basal cell carcinoma type lesions throughout the body, even on non-sun exposed areas, then that's when you go ahead and lock in basal cell Nevis syndrome as your answer choice, not basal cell carcinoma. All right. There are many types with varying degrees of pigmentation, ulceration, and depths of growth. Nodular, superficial, and sclerosing are the three main types. Confirmed with a shave biopsy, which will show nests of basophilic cells invading into the dermis. Excision via curettage, cautery, cryotherapy, superficial radiation, and of course, again, Mohs surgery, where you basically cut off thin slices, right? Just so you don't do like a really ugly surgery that makes the person feel aesthetically displeasing. Right, so basal cell carcinoma. Of course, the various types that exist are not the biggest deal, as long as you can identify the key things. Right, the key things. So all of these images for basal cell, and then all of these images for squamous cell. Very important to be able to identify. Now, there's something here that happens that's kind of disturbing. It's very interesting to see how similar this lesion and this lesion look to each other, right? If you look at nothing but the lesion, if you look at just the lesion alone, these two guys look so goddamn similar to each other. But there are key things that are going to help you differentiate between all of that, because G is actually the next thing we're going to look at. It's a nodular melanoma, right? So that becomes a little problematic at that point, right? Because then you're going to get a question where they show you these things and you're going to be a little confused. So before we do that, let's take a look at this question at the top real quick. It was just the question itself was nice, so I didn't really need to put much of the explanation there. 65-year-old man comes to the office 4 years after a burn injury to his left leg that required extensive local care and skin grafting, resulting in significant residual scar tissue. During the treatment of the burn, he also developed a chronic draining wound that never completely closed. For the last 6 weeks, he has had an enlarging nodule at the lesion site associated with persistent pain and increased drainage. Treatment with topical therapy has not helped. On biopsy of the nodule, what is most likely to be identified? Most likely, you're going to identify squamous cell carcinoma, because what this question did, and the reason I put it here, is because it did a really nice job basically using this image that's being painted, right? They told you here that people who have sun exposure, which is the most common thing we always think of, are at risk, but then there's other stuff. There's people with sites of burns, chronic trauma, and even draining infectious sinuses, right? So they used all of that in that question right here, right? So there was really nothing else in the question to make you think of squamous cell carcinoma besides the fact that you studied this and then it rang a bell for you, right? So this guy basically has trauma, burn, draining lesion, etc., and now he's got this enlarging nodule at the lesion. It's probably cancerous, and you're going to discover squamous cell carcinoma. You're not going to discover basal cell carcinoma there, right? Basal cell carcinoma doesn't have any kind of thing besides the sun exposure that can cause basal cell carcinoma, right? So that's why you wouldn't pick basal cell carcinoma for that one. Next up, melanoma. This is the most common life-threatening dermatologic disease in general. Risk factors include fair skin and a tendency to burn, intense bursts of sun exposure, and the presence of large congenital melanocytic nevi. So this is another topic that NBME, the step 1 NBMEs love asking about, melanocytic nevi. So we'll take a look at that. An increased number of nevi or dysplastic nevi. Immunosuppression also increases the risk. Some patients inherit a predisposition to melanoma with the familial atypical mole and melanoma, right? So that's what FAM-M syndrome is. Familial atypical mole and melanoma syndrome. This was actually in an NBME question for step 1, where they had a patient who had things that looked like, well, basically had a bunch of moles as they described it in the question, and it was in the family. So when questioned about the mole, the kid was like, oh yeah, this runs in the family, and his mom confirmed that. And then the question basically asked you, what should you do about it? And yes, it was dangerous. It was at risk of melanoma, so you had to I think in that question you had to start like actually getting rid of the moles. So excision was the answer there. So definitely worth remembering this, right? This kind of stuff can pop up. Malignant melanomas begin in the epidermal basal layer where the melanocytes are found. Malignant melanomas may metastasize anywhere in the body: liver, lung, brain, fat. 3% to 5% of patients with metastatic melanoma have no known primary lesion. Right? No known primary lesion, which means they could have a primary lesion. They just, you just never knew it was there. Because a melanoma, the type of, let me see, they don't have a picture for melanoma. Melanoma, depending on the type of melanoma you have, you might not always know it was there, and especially if the person is of a little bit darker skin, right? Not someone that's very white skin. But these are all pictures here. Let me see, for melanoma, everything from F to I, right? So, what about E? What was E? Oh, E is a keratosis. Okay, so F to I. So everything from here to here, all of these things, right? So all of these things are your melanoma images. And look at this over here, for example. This is a darker skinned patient. This is actually also an NBME question, that usually darker skinned patients will have melanoma on the places where they have whiter skin, so like the soles of the feet and the palms of the hand and stuff like that. Now, if you have melanoma here, and you never, how often do people really look at their heel? It's not really that common to sit down and take a look at your heels. So if you don't look at this part of your body, you might never know it was there. Thus, you have no known primary lesions, and this can then metastasize to anywhere else, leading to death, like the brain or the liver. It's very dangerous, primarily because of the fact that it can metastasize anywhere. That sucks. That's really weird, right? That it can go anywhere. Early recognition and treatment are essential. Screening exams using the ABCDE criteria and dermoscopy may detect melanoma early when it is curable. An excision biopsy should be performed on any suspicious lesion, right? So here now, because of how dangerous this is, you do the excision biopsy, right? Even on the first thing we talked about, the seborrheic keratosis, if it's not very clearly seborrheic keratosis, then you should do a biopsy to exclude melanoma in that case. Here you definitely want to do it because this is so dangerous. You want to make sure 100% it is melanoma. Also because the treatments that are out there for melanoma are very expensive. So the insurance companies won't necessarily pay for your pharmaceutical needs unless you prove that it is melanoma. You don't want to waste money treating something you don't have. Malignancy is determined histologically. A biopsy should be performed on a mole that is substantially different from other nearby moles so you can assess for melanoma. This is the ugly duckling sign, where one mole looks very different from all the others. Then you start thinking melanoma. And this has greater than 90% sensitivity for melanoma, right? So all your moles, generally speaking, should look pretty similar to each other. If any one mole looks super different from the others and it really stands out, and the fact that you have more than one mole in this similar area is all indicative of possibility for melanoma. Malignant melanomas are staged by the Breslow thickness, which is the depth of invasion in millimeters, and by tumor node metastasis staging, TNM staging. Ulceration is a poor prognostic sign. Right, so this is the melanoma depth of invasion thing. You have your Clark levels, which basically talked about the Breslow depth. Right, so the deeper your Breslow depth, the higher Clark level you're at. Right, and the worst one is number 5, of course, right, where it has actually invaded all the way to subcutaneous fat. Right, so that's your Breslow depth of 5 and a Clark level of 5 as well. So again, because it can do so much, it can metastasize and invade so much, it's extremely dangerous. Treatment: lesions confined to the skin are treated by excision with margins. Sentinel lymph node biopsy is useful for staging but does not increase survival. Chemotherapy, biologic therapy, and radiation therapy may be used for recurrent or metastatic melanoma. Patients with early melanoma are at low risk for recurrence but are at high risk for the development of subsequent melanomas. More advanced melanomas may recur or metastasize at a higher rate. patient surveillance is essential, right? So that's definitely something you pick in the answer choice. You keep having the patient revisit and keep making sure that they haven't developed new melanoma or that any melanoma is worsening. Now, they didn't, of course, go into depth here about the ABCDs and all that stuff because they're assuming you did step 1 first and you studied it there, right? So that's all right here, and we looked at it a little earlier. Asymmetry, border irregularity, color variation, which looks like this. So you see how this half is much darker than the rest of this, right? This is melanoma, right? So this stuff is not so dark at all. Here is super dark. That's indicative of melanoma. Then you have many types of melanoma, of course. And again, you can see the color variation here too, by the way, because the entire lesion is this big, okay? But then you really only have the dark part right here. That's melanoma, right? And it looks like that image is on the face. This is an eye bag right there. So, and there's many types, right? So they tell you here, it's including superficial spreading, nodular, lentigo maligna. So lentigo maligna is this one right here on the face, whereas the nodular one looks, where is it? G. Yeah, nodular one looks like this, which is very similar looking to your squamous cell carcinoma we have here, right? So again, it's all based off of everything else you see in the patient and what else is presenting on them. The main difference between these two lesions is really where they are. So you can't really differentiate between the two lesions if you only look at the lesion. This kind of stuff with squamous cell carcinoma only occurs on the lips. Otherwise, anywhere else, squamous cell carcinoma will look more like that. Right? So on the lips, it looks like this because of the way the body is on the lips, the way the texture of the lips are. It can look like this on the lips only. Whereas here, you see melanoma looking like that on the skin, and that's very malignant. All right. They also mentioned a medication here. So basically, you can do, there's the BRAF kinase inhibitors. You can use these for all patients who have the BRAF V600E mutation, right? So vemurafenib. So it has the RAF in it for the BRAF kinase inhibitor. So you should be able to think of it for the most part. But again, it's something that will have to come to your mind when you're doing the question. So yeah, there are medications for it. There are ways to treat it, but it's really, really problematic depending on what point in someone's life you discovered it. Here, by the way, is another one where you're seeing, right, that in darker skinned people, right, and in Asians, by the way, it can be on the palms, soles, or nail beds, places where you would definitely have white skin regardless of your race or gender, right? So that's something to keep in mind. Weird questions can pop up and you should be able to figure out what's happening. And before we close up for today, let's take a look at this question and then I'll come back later on to continue on the rest of this. So this question on the left says, a 62-year-old woman comes to the office for evaluation of a pigmented lesion on her left forearm. She first noticed the lesion 4 months ago and says it occasionally itches but is otherwise asymptomatic. She also has numerous freckles that she attributes to playing golf during the summer. Medical history includes psoriasis, hypertension, and mild COPD. So psoriasis being something that is dermatologic and problematic, right? So she already has something like that, which is pretty autoimmune as well. She quit smoking 5 years ago and drinks 2 to 3 glasses of wine a week after golfing. So the golfing part tells you that she's definitely in the sun a lot. On exam, there is a 5 millimeter dark brown lesion. It didn't tell you if she's white or black. Okay. So 5 millimeter dark brown lesion at the dorsal surface of her distal left forearm. It has a smooth border and a small eccentric nodule. In addition, multiple scattered flat light brown lesions are present on the nose, cheeks, and dorsal surface of the hands. What is the most appropriate next step in management for her lesion? So now, the correct answer here was to do an excisional biopsy. 55% of people picked it, but 30% of people chose re-exam in 3 to 6 months, and 10% of people chose shave biopsy. And I can totally see how they all seem like, pretty plausible answer choices. But excisional biopsy was definitely what you needed to do here, right? So they tell you here, screenings and excisional biopsy, right? That's the answer. So this is how your answers come to be. Your answer choices come pretty much straight out of the book. What do you do for diagnosis? You do excisional biopsy. The ABCDE criteria is not very effective in identifying nodular or atypical melanomas, which is what this patient has. Nodular ones account for 30% of all melanomas. The ugly duckling sign has a sensitivity of up to 90% for melanoma, and her lesion is an ugly duckling, right? And they did a pretty good job telling you that. They told you that she has this one dark brown lesion, which is basically one mole, that is smooth borders, small, and has this weird, right? Eccentric is pretty much weird nodule. Other than that, she has a bunch of other ones that are also light brown, and they're all over her body, but they all look the same. But this one has an eccentric nodule to it. So you need to do an excisional biopsy, right? That's your ugly duckling sign right there. Very nicely hidden into a question where it might not ring a bell for much at all, and then all the answer choices might look pretty viable to you. So very important to keep in mind the ugly duckling thing, right? It's pretty high yield. It's not just a waste of time right there, right? Re-examination would be for an atypical nevi, and shave biopsy would be the answer for something completely different, like we've done a couple earlier. It's not recommended for suspected melanoma, as partial removal may not provide enough tissue for diagnosis, right? Because you have to see the depth of invasion to really know how bad it's become. Shave biopsy is not really something you want to do for melanoma. You could do it here because, you know, these things can be problematic. It's to do any worse of a biopsy. You're definitely not going to do a punch biopsy on a face, right? You really don't want to do an excisional biopsy on the face, and these things that are on the face, basal and squamous cell carcinoma, or on the head, it's a little harder to do anything else but a shave biopsy there, right? So shave biopsy were for basal and squamous cell carcinoma. All right, so knowing the next step in management is a very CK type of topic, and you want to make sure you focus heavily on diagnosis and treatment, right? Diagnosis and treatment every time you look at something in CK, because when we did step 1, it was all about this area, knowing how it looks, what it presents with, all the little bullshit topics about it, blah blah blah, and then what the patient would possibly have in their history. But now we don't care about that. We're going to be given all of that, and then we're going to have to use our clinical knowledge to figure out what to do for diagnosis and how to deal with it. All right, so thanks a lot for joining, guys. I hope that was helpful. In the next video, we'll move on to Kaposi sarcoma and the rest of your neoplasms of the skin.